Once you have the individual components of your breast MRI program established, you will soon be ready to begin imaging patients. At this point, the question arises as to who should be your first patient imaged. Before discussing who should be first imaged, I would like to give some advice as to who you should avoid imaging early on in your program. The high-risk screening patient population is a population of patients that are most optimally left until after you have gained some experience, both with your program as well as with breast MRI interpretation. This population of patients is generally younger. They tend to have denser breast parenchyma, which is often hormonally more reactive and commonly associated with moderately prominent background fibrocystic changes. These can all result in moderately prominent degree of enhancement of the parenchyma, which can be difficult to evaluate, particularly when you have little experience. Additionally, in this patient population where tumors can sometimes behave in a more biologically aggressive manner, you may not have the luxury of following a questionable signal abnormality as you may in a normal population. For these reasons, we would strongly recommend you gain a significant amount of experience with performing breast MRI and breast MRI interpretation before allowing this population to be imaged. You may decide to just proceed with routine scheduling of patients, possibly with the exception of initial exclusion of high-risk screening patients. This is certainly a viable option and one that may work well for you. There is, however, the possible scenario of having multiple negative MRIs with your initial patients, which will leave you somewhat anxious as to whether these were truly negative MRIs or as to whether or not your program is flawed or there is some other technical issue which is preventing you from identifying cancer. The approach that we took as we first developed our breast MRI program was to begin imaging patients with known breast cancer diagnosed by standard imaging that had already elected to proceed to mastectomy. We found these patients by speaking with our breast surgeons and asking them for several referrals. We met with the patients ahead of time and explained to them that this exam would be performed free of charge, and also explained that this exam was unlikely to personally benefit them in the evaluation of their cancer. However, we did hope it would benefit future patients. We were amazed at the willingness of multiple patients who readily agreed to proceed. We then performed these exams and developed a diagram of the breasts on which we would map out all of the pathology that we identified. We then met with our pathologists at the time of the gross sectioning of the mastectomy specimen. Using our diagrams, we would direct a pathologist to all areas that we felt indicated cancer or at least were suspicious for malignancy. Utilizing this approach to imaging our first patients was particularly beneficial, as it first of all helped us to run through our imaging procedure on a number of patients in a scenario where results were unlikely to have a significant impact on patient care. We had an opportunity to evaluate each component of our system and identify any difficulties that may exist, such as with our CAD system in determining CAD sensitivities, modifying hanging protocols, or working out difficulties with protocol recognition. It also allowed us to gain confidence in our protocols as we were able to identify known cancers and even in some cases unsuspected cancers. Once we completed imaging of a number of known breast cancer patients, we had worked through many remaining problems in our workflow and had developed some degree of confidence in our ability to identify cancer. We then felt much more prepared to proceed with routine diagnostic imaging.